Good day, all, and welcome to the Teledyne Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities.
Hello and welcome to the Teledyne Pulse. Shane, last time we talked a little bit about providers and their impact on a hospital program. Before that, just looking at the overall hospital strategy when it comes to things like digital health. So today, we're going to talk about nursing, and this is a deep subject.
It's a deep subject, all right. Holy moly! This is going to be a fun section. We're into the third pillar here of your considerations for digital health strategy, and nursing and ancillary services is an important topic, and one that I would say wasn't really a focal point up until a couple of years ago, really, and rightfully so,
for sure.
And I think it's interesting that, by the way, you should go back and listen to, if you haven't, the strategy session 1 with hospital strategy, and then number 2 on providers, and this being the third one, nursing and ancillary, is going to be a great session. And nursing and ancillary services, as I mentioned, if you look back across the number of conversations we had around this, going back 10 years ago, was very few up until about 24 months ago.
Yep.
And a couple of things emerged as to why we started diving into this space. We felt it wasn't, believe it or not, it wasn't so much, the reason we got into this space wasn't so much that, oh my gosh, this is going to be a market trend. We need to be in this space, need to be doing this space.
Right.
What really emerged from my perspective, where this really hit me, was in a strategy session with a hospital. I don't remember the hospital off the top of my head, but part of the transfer analysis tool that we were working through, and what we found was the nursing workforce particularly in the evenings, the transfer threshold was through the roof. I mean, it was absolutely through the roof. And then in talking with some nurse executives that were in the Northeast, in some larger systems up in the Northeast, and this one nurse executive had 400 plus nurses through her system, and of the 400 nurses, over 50% of them had less than 3 years experience. And we've absolutely attributed in our transfer analysis tool that low levels of experience absolutely increase transfers in rural hospitals and in regional hospitals. And so for us, again, getting back to kind of what we've built our entire company on, about not being a financial boneacher for our institutions, but rather a great partner and a genuine interest in having them be successful, we felt compelled to build this type of model to help hospitals address that issue.
Yes. Because
as you start doing a deep dive into the data, it's relatively scary in terms of where we're at with nursing. So that was really the primary reason why we got involved in this space. And I think it's an important precursor, really, to have this conversation as to why we got involved in this space in the first place.
Right.
And so it's not that it's necessarily a new concept. It's been around a while. But to the level it needs to get to and the sophistication it needs to get to, it is different today than it was prior to the pandemic. And that being said, last year, 2023, was the record number of people turning 65, the all-time high. And from what I understand, it's the peak, but essentially it's plateaued there for the next several years. And so the population is getting much older, and the baby boomers are all now hitting 65. And it's not a secret, right? They're going to seek more medical services
and more complex medical services
at that age.
Yep.
And it behooves us to be able to provide the resources to our hospitals to be able to address and manage those needs moving forward. And so that's a significant concern. And then based on the pandemic, and this isn't often talked about, the reaction to the mass exodus of nurses from the nursing workforce was well publicized. I mean, it really was. I mean, the thousands and thousands and thousands of nurses that left the workforce. Not only did they leave, but what they left with was the big factor, which was their knowledge and their experience and
Absolutely.
their skills.
Yep.
And so, although there's the number of nurses that left was significant, the number of years of experience lost was in the millions.
Yes.
And that's really where the rubber meets the road, where my main concern lies, because there's been a lot of emphasis on pumping new nurses into the workforce. And we're in a lot of different parts of the country. I've talked with a lot of different C-suites across the country and at conferences and speaking engagements, et cetera. And the general tone of the perception of the nurses coming into the workforce today from a skill set isn't terribly positive as a general rule across the country. And so my thoughts on that are, well, we can either complain about it or try and address it. And how do you do that? Because it's so hard today. When I'll give you an example, talk with a hospital. Well, Shane, my night staff here, I got 10 nurses on. All of them have less than 2 years experience, and my charge nurse has 3.
Right. And that's why she's the charge nurse, because she's got 3.
And you're kind of scratching your head going, well, how's this going to work? How are you going to legitimately provide any sort of mentoring type of resource and strategy on an ongoing basis in that environment? It's very difficult. And so it's absolutely an issue for us to try and keep more and more patients in these hospitals if the nursing staff is reluctant to take care of these patients, or they're concerned because they've never seen this type of thing before. A couple of quick examples. We have in our acute neuro and stroke program, we're keeping 73% of all patients in the rural hospital that we see out of the emergency department, which is incredible, including critical access hospitals, post TPA, the whole 9 yards. And when you have you're trying to admit that patient, and the admitting nurse is going, well, wait, what do you mean I got to do hourly neuro checks?
Right.
What's that mean? Or what do you mean they received TPA? And I vaguely remember what TPA was, but oh my gosh, well, isn't that's a problem, right? And so what they need support. They need a resource they can go to have those questions. And yes, is our neurologist and stroke team available around the clock to beam in and talk to the nurse if they need, or see the patient? Absolutely. But in a lot of instances, they need a nurse. They need a nurse they can talk to that's seasoned, that's a veteran, that has experience, that's seen that, been there, done that.
Yep.
And I really do believe that we can make an impact on that front by offering that real-time mentoring type of strategy in those scenarios where if I'm the admitting nurse and I've never seen this before, it'd be great to be able to have a nurse beam in with me and just, hey, am I doing this right? Or not that you'd ask it that way in front of the patient, of course, but where that nurse mentor offers that emotional connection and that confidence level of satisfaction that says, you know what, I have my virtual nurse partner in my back pocket. I can call them if I have an issue or concern. They can beam in and look at something with me, or review the chart with me, or if I have a question, and that's huge. So it really does a couple of things. One, it gives your local nursing staff confidence that they can be successful in this. And then ultimately what it does is improves their satisfaction, because if they start feeling pressure to admit patients they're highly uncomfortable with, it makes it very difficult.
Well, and that goes back to retention and recruitment of nursing staff.
It just does. And speaking of that, the average age of the nurse right now is 52, 53 years old. So we still have a lot of nurses in the workforce that are not exactly 20.
Nope.
They're not 22. 1 million plus are expected to retire over the next 8 years. And, the shortage of workers is significant. But there's, I want to say somewhere around 77, 78 million people are going to be 65 or older by the end of this year. And hundreds of thousands of nurses short. And so, yes, we can continue to pump brand new nurses into the workforce with little to no experience, and some would argue the skill set is low, and it's not necessarily all on the local nurse. Again, how do you build those skills? You need touch points, right?
Yep.
You need those interactions. You need those skills to develop and hone over time with proper mentoring and orientation, et cetera. But it just takes time to hone those skills. So we needed to find ways to augment that. So nursing is absolutely going to be a factor. So then that brings us to virtual nursing. And what role would that potentially play as part of this strategy? And virtual nursing has been around, as I mentioned before, for quite some time, generally in the larger institutions, generally inbred in terms of larger hospital systems using local employed nurses that work at the facility in a hub in the basement or whatever that's providing the service. I do see that the new virtual models where we've seen some of those models struggle for various reasons. I won't get into those reasons for the purposes of this podcast, but there are detailed reasons why those programs have struggled. Some of them, not all of them. Some have been very successful. Others have struggled for various reasons. But I do think it is going to be imperative that all virtual nursing programs have a partner that is able to augment their virtual nursing strategy and program externally, as opposed to relying 100% on internal nursing staff. And I would argue that's probably going to be the case whether you're large or small, in terms of the hospital size, particularly if you're small. It's really a non-negotiable, really.
Right.
So I do see those hybrid models coming to fruition. And I'll start with going through some of the information that's coming out of some of the virtual hospital programs and some of the larger institutions. But we've absolutely seen dramatic impact in those hospitals. And a lot of the things that went away during COVID, just because of resources.
Yep.
Things like discharge education that kind of fell off the map. That didn't even happen, or high-risk med discharge discussions, or specific patient education. Those sorts of things just didn't happen. The discharge documentation was substandard, was quick, trying to turn over patients. Hospitals are full, staffing's low, ratios are off, experience is low. I mean, it's just the perfect storm of a mess, right?
Yep.
And so subsequently, we've seen an uptick in readmissions in certain areas because of those. Not all attributed to those factors, but those are a factor. Right?
Yeah.
And so along with that, a dramatic increase in locums nurses or nurse agency nurses, whatever you want to call them, agency nurses, locums nurses, travelers, the whole nine yards. Mm-hmm. And so although many hospitals have taken stances to try and mitigate nursing staff and travelers, which kind of gets back to our physician discussion earlier in terms of identifying where you're spending time. And most hospitals are very keenly aware of what they're spending on traveling nursing.
Yes.
Very much so. And the question is can virtual nursing address issues around that? And I think it has to get back to, as you start having these discussions with the institution, not so much about what are the dollars you can mitigate that you're currently spending on travelers or locums nursing versus a program that addresses multiple issues as opposed to the dollar equation. So I think when folks start talking about virtual nursing strategy, they tend to gravitate to, we're spending X on locums, we want to spend X on virtual nursing, and what's that do to our FTE allocation, staffing ratios, those sorts of things. But really, you need to, from my opinion anyway, my perspective is to look at it from more of a recruitment and a retention and a mentoring strategy going in as part of it's really a necessity to do business, as opposed to what are you going to mitigate on the cost side of the equation. Now, it's an important thing to consider. I get it, and I don't disagree with that.
Right.
But to have that front and center as your only metric is a difficult proposition, because at the end of the day, that will take care of itself. We've seen that happen, where over time, as the program matures, the locum stuff goes away. You're not using travelers anymore because your retention improves, your recruitment ability improves, your nursing satisfaction improves. That takes care of a lot of these other problems that you're trying to address right out of the gate. So it's really your approach and how you look at the equation. And so to approach it from a quality perspective and a patient satisfaction, nursing satisfaction perspective, nursing recruitment tool perspective, and encouraging young new nurses to come into the workforce with this level of support available to them, it's a big deal. And it gets back to trying to quantify those types of downstream ramifications of having this type of program in place. So, but it is absolutely a factor. But we've seen, for example, in one of the larger programs, an overtime reduction of 50% in overtime, a reduction of 20% of contract labor, and that's actually continuing to decline in terms of contract labor. That improves really every 6 months. That's improving, and eventually that'll go away. The sitter cost and virtual sitting, which is also, we'll talk a little bit more about that here in a minute, but sitter cost down 75%. Nursing turnover down 30%, which is a big deal. You know, again, this gets back to retention, right?
Yep.
So retention, satisfaction. Falls and fall injuries down 50%. Lengths of stay down 0.2 of a day, which is a factor in the PPS corridor, not so much of an issue in critical access hospitals. But nonetheless, and by the way, this is a larger PPS hospital, not a critical access hospital. HCAP scores improved by 25%. Nursing satisfaction dramatically improved. Recruitment ability improved. And so those are the types of things we're seeing that are fairly common in a lot of the virtual nursing programs that are done well. Again, there are others that have struggled. And generally change management's at the front end of that issue in terms of struggles. I'm not going to get into all of the struggles, but there's definitely a handful of issues that are very, very likely the culprit in a failing virtual nursing program. But one of the things to consider as part of that strategy as it relates to a virtual nursing program is really what you're trying to accomplish, and focusing on just simply being there for the nurse and supporting them at all hours of the day. And if you do have issues with lengths of stay, virtual nursing can absolutely make a difference there. Better discharge management unequivocally is better this route. They can spend more time with the patient, more time with the family. Satisfaction improves. Readmissions go down in most cases. Not that it mitigates all readmissions, but at least you put your best foot forward, make sure the prescriptions are right, leaving, that the med rec's done correctly.
Patient understands their medication.
Well, that remains to be seen, of course, but at least they have the opportunity to do that. There's obviously factors that coincide with patients' understanding of that, but really there are a multitude of factors that a virtual nursing program can bring to the table that you otherwise don't get without that in place. So if you're having throughput issues, that's a factor too. We'll talk about some of the more specific metrics in our fifth podcast on this front, or fourth podcast. But nonetheless, there's a lot of options for virtual nursing. As it relates to PPS, let's talk a little bit specific about PPS hospitals now. You know, if you're having issues with falls or bed sore issues or bed checks, chart checks, admission documentation issues, or admission throughput, where the nurses are just spending too much time in the charts, which is a common complaint from nursing staff, is spending too much time in the EMR. But to have a virtual nurse offload that admission documentation and assessment is a big deal, big deal. It oftentimes can improve throughput. It also improves the amount of patient contact that the bedside nurse can have with the patient, which is a huge satisfier for both the nurse and the patient. So that's a big deal to offload that. Chart checks, if they're not getting done, they can handle that, or routine chart checks of various types, checking quality metrics and scores to make sure certain things were checked off or certain things were done that were not done. Cross-checking meds, cross-checking, various things that need dual checks before administration. Those sorts of things are very helpful for virtual nursing staff to accompany the patient, or the bedside nurse. So a lot of options there that could help on the PPS side.
Yep.
When it comes to sitters, that's a big factor. We're seeing a lot of that. And patients, by the way, virtual patients, they've been around a long time, for 10 plus years, of various types. But we're seeing definitely a proliferation in the patient sitting corridor. And the nice thing is, particularly in hospitals that are a little bit larger, that have a large sitting FTE base, we've seen scenarios where you can cut your FTEs almost by 75% in terms of the cost, which is a big cost savings, right? Yep. And so the patient sitting factors really dive into a couple different areas where, in terms of an ROI proposition on that front for the larger hospitals, is what are you spending to have sitters today? And if you put in virtual sitting as part of the program, what does that mean in terms of an ROI proposition? And then what does that mean in terms of patient perception? And what does that mean in terms of fall risk mitigation, fall reductions? Are you going to make improvements there? So, for example, do you have patients that really could use a sitter today that you either don't have one, or you couldn't afford one, or since just in terms of they're all busy, so you just didn't use one for this particular patient? The nice thing with virtual sitting is you just turn them on, right? Not quite that simple, but at the end of the day, you're turning them on. So, and that gets into, of course, the technology discussion, which we'll have in the future podcast in terms of tech stacking strategy. Those are all things you need to consider as part of your technology platform moving forward. But the patient sitting, as it relates to that, too, a couple of other considerations. What we've seen here over the last couple of years is, in some instances, patients are reluctant to have a camera that's watching them around the clock. And in some instances, they've refused patients sitting that's going to be watching them around the clock, which is a little oxymoron in terms of, if I'm okay with Andy sitting in my room all night watching me, but a camera, so the level of paranoia around, or where you delineate this is okay versus not, camera versus a live human being in my room, is, I'm not sure why one would be okay and not the other. But nonetheless, we do see that from time to time. So I think the AI assisted capabilities with your patient sitting strategy is important, and the ability to leverage other things like a LiDAR, radar strategy in combination with your camera strategy is important when it comes to creating what we call sort of a smart room strategy as part of that fall risk mitigation and overall patient safety mechanism, which also gives you a little bit more leeway in terms of monitoring the entire room and even bathroom in some instances, as opposed to just the camera focused on the bed. And as the AI is associated with that, if you're doing these types of programs on your own, the jury's still out on exactly, depending on where the AI lands in association with the number of patients that could be safely monitored, the jury's still out on that. But at a minimum, the AI is very helpful in assisting who is monitoring them with making sure that they're alert and zoning in on the right patients they need to be to make sure they're preventing falls. So very helpful programs can absolutely make a big, big difference, not only financially, but in fall preventions, among other things. So fantastic programs. When it comes to the virtual nursing side of the equation, when it comes to ROI, it's all about change management going in. Several different factors to consider as part of your change management strategy. One of which is not to start off with a meeting with your nurses and say, we are going to shift your patient ratio to 1 to 20. Something like that. That will not work.
Won't go well.
It will not work. In fact, right out of the gate, I would make it a point to address that, to say there's no plans to change anything along the lines of patient-nurse ratios. We'll see where the dust settles once the programs mature and see what happens. You may get some benefit, but there again, it kind of gets back to the rationale and the reasoning back to the why you're putting in that program versus if you go in thinking I got to increase my patient ratio by 1.5 patients per nurse, that's the wrong way to look at it. And you're going to struggle to have a successful program under that mindset. So those are a couple of tidbits as it relates to nursing. I will talk a little bit now about nursing as it relates to critical access hospitals as opposed to PPS. And I've said the jury's still out. The jury's still out on this one too, Andy. I think the critical access rural hospitals have been accustomed in some instances to nursing support in the ED and in emergent situations. They assist with documentation and transfer logistics, those sorts of things. So that's been around for quite some time. But what we really need is the ability to engage the nurse not only in the emergency department, but on the inpatient unit in a mentoring type of capability and strategy that covers not only the ability to handle those scenarios I previously mentioned, but we really need to have somebody that they can go to just ask questions. and to be able to mentor them in real-time situations, and then follow them to the inpatient side, or follow that patient to the inpatient side, to then give additional comfort to those nurses on the inpatient side of what's going on. Yep. So obviously in a critical access hospital, you're not going to be trying to reduce your sitter cost by 75%, or you're not going to be looking to, have the significant impacts in your falls and your overtime. You're going to impact those areas, of course, not to the extreme that a large hospital is, right? But for the critical access hospital, the focus really needs to be, in my opinion, more on the mentoring strategy and supporting the nurse knowledge base and skill set to then improve retention, improve recruitment, improve overall nursing skill set and satisfaction long term, which then perpetuates their confidence being higher and keeping more patients there.
Yep.
At the end of the day, that's your strategy going in to a critical access environment. Now we're moving those programs out, and we're very excited about those programs and the impact that they're going to have on the critical access hospitals long term. In the end, we'll see how these go with the early adopters that we're moving these out in, but I remain very optimistic that they're going to provide a significant value benefit for our rural hospital partners, as already demonstrated in the larger markets.
Yep.
Well, I think that kind of covers, Andy, more the nursing side and the ancillary side of the equation. I think now what we're going to do is shift to more of the ancillary side.
Sure.
And this is an area that I think as you and again, this kind of ties together the technology strategy long term, again, which we'll talk about later podcasts. But really, one of the things that also emerged from the pandemic was the need and the necessity to bring other individuals into the equation. And so that's, again, the evolution of the virtual nurse, the evolution of patient sitting.
Yeah.
But I also think it brings with it another angle. And the other angles involve things like language interpretation. Again, that's been around for years and years and years. Mm-hmm. That's nothing new. But how do you seamlessly integrate that as part of the strategy? And then things like respiratory therapy. And so as you start picking off things that why can we not keep a patient here? Mm-hmm. Why did this pulmonary patient have to be transferred? Well, Shane, the reason we had to transfer that one is our respiratory therapist is brand new, has no experience, was uncomfortable with that patient, and so we had to transfer him.
Right.
Okay. Well, what if we have a virtual respiratory therapist that could assist that? Oh, gosh, that'd be great. Mm-hmm. Then I think we maybe could have kept that patient here. So, or maybe they don't have RT at all. Would they enjoy having an RT available to weigh in on a BiPAP scenario or a vent scenario? So I do see a significant role for respiratory therapy moving forward as part of ancillary services, and then pharmacy. And when you think about these services, I wouldn't always, as an administration, I wouldn't always think about external resources. I would think of it from more of a hybrid sense. In other words, do you have local respiratory therapists? So, for example, maybe you have one that's there, boots on the ground 3 days a week, but would be willing to beam in the other 2 days a week, to come in virtually from home. Well, that's something you'd want to consider as part of that process. Same thing with nursing. We're working on a decentralized model, which has nurses in a bunker and nurses that are remote at home and nurses that are local, in some cases within a bunker in the hospital.
Right.
And sort of building those hybrid models around those services is going to be important. Pharmacist being another one of those that you could leverage internal pharmacy, you can leverage external pharmacy support, and really getting that pharmacist expertise to the bedside in a way that gives you the ability to address those high-risk med situations or med questions in general. And even in a huge tertiary center, if you think about it, how's the pharmacist more productive? Can they be more productive by beaming into each room out of the pharmacy versus running up on the third floor, fifth floor, eighth floor, sixth floor, doing all these boots on the ground, in-person education scenarios? Right. So, in other words, a plausible question would be, can they be more efficient from doing this, just beaming into each room from the pharmacy?
Well, and that it's not just the pharmacist's efficiency then, it's the nursing efficiency because they're waiting for the pharmacist. They can't get the patient out of the bed until the medications have been reviewed, and it's kind of snowballs.
It sure does. It sure does. And so I do see that the pharmacist is the role of the pharmacist is also going to evolve in the virtual space. I think historically, e-pharmacy's been around for decades, right? That's been around a long time. But I think I see that morphing where you're going to start seeing the ability to bring more remote pharmacy expertise to the bedside as part of the programmatic strategy. To then help with those types of discussions. Case management is another one that oftentimes not thought about, but how do you bring a case management strategy to the bedside? And as you think about all of these programs that, well, we don't have a case manager, we don't have a social worker. Well, what if you had access to one virtually?
Right.
What do you think about that? Would that be helpful? Well, gosh, maybe. I don't know. Would that be helpful? But so I do think you're going to start seeing things like social work, case management, leveraging these types of solutions to help hospitals in those scenarios. Pastoral care is another one that has come up as a need for hospitals that are lacking pastoral support. And there again, if you have no pastor that's available, or if there's a particular specialty that they're looking for from a pastoral perspective, or whether it's a priest or a pastor or whomever they're looking for, and maybe you don't have that, but maybe you have an organization that'd be willing to provide this virtually into the hospital, in which case, and as you think about this as a patient, right, as your patient, and you think about, let's say you're in a bed in a hospital and the pharmacist, the virtual nurse beams in to do your discharge education. Then the pharmacist beams in to do your high-risk med discharge education, answers all your questions related to your new blood thinning medication and ongoing support for that. The virtual nurse handles your follow-up appointment questions. Your bedside nurse comes in and does the final checks and sign off everything and make sure everything's looking good there. The case manager came in before that virtually and went through discharge planning strategies, follow-up appointments, maybe you need home health, setting that up for you. Maybe you had a virtual pastor that visited you on screen as part of your stay. And think about it. Just think about it for a second. And if you didn't have that solution in place, you've got no pastoral care, you've got no case management, you've got no pharmacist talking to you, you've got no virtual nurse doing the support.
Nope.
Which patient's going to have the better experience, do you think?
Well, which patient's going to have the higher satisfaction?
Well, more than likely. So it's all about thinking about this globally and what we can offer as part of a programmatic strategy to a hospital. So, and to your patients at the end of the day. Another significant area that will grow is the virtual therapy support modules. So physical therapy, occupational therapy, speech therapy. There's already been some growth. There's been some sustainable growth in the virtual markets for those services. There's even some coding now available for professional fee acquisition as part of those services. So I do see the ability to augment local therapy resources, such as therapy assistants, with virtual, properly trained physical therapy and properly trained occupational therapy or speech therapy. And speech therapy may not even need the assistant on site, right? But the other components really does bring that level of expertise to the bedside that you otherwise wouldn't have. And in addition to that, if by augmenting that virtually gives you the ability to retain that patient in an ongoing rehabilitation strategy, that's a big deal. Versus, you got to go to Omaha or Lincoln or St. Louis or Lexington, Kentucky, or wherever you're going to go for those services. So it's a big deal to think about it from the whole scope as your programmatic strategy. And of course, this all ties into, as you think about that scope, then you got to think, what should my tech strategy be as part of all this, which we'll get into in a later episode. But it really is, as you consider your digital health strategy, these are all various things to kind of take into consideration. And unfortunately, you go through these different things with hospitals. It's sort of like drinking from a fire hose, and they're going, well, where do we really start with all this business? And this really just starts just with the evaluation and really having a firm understanding of all the variables, everything in front of you, and then building a program in an incremental fashion around those needs. But in the end, I do see virtual nursing as a significant factor moving forward,
Absolutely.
and all the ancillary services associated with that.
Yep. We talked about, looking into the data and things like that. It sounds like maybe you're setting us up for our next session.
Well, certainly there's other, obviously in the first session, we talked about some of the hospital strategies and more market specific strategies. We'll get into a little bit more specifics in terms of metrics that you may want to identify as a hospital, both large and small, and how specific solutions could be designed around those specific metrics that you're having challenges with that maybe you haven't thought of.
Yep.
For example, why my leapfrog scores are X, Y, and Z. Why would a virtual solution be able to help in those scenarios? Or, my adjusted case mix is X, or my length of stay in the ICU is this. So there's various metrics we'll go through and offer a couple of insight items on and case examples of institutions that when we've done these strategy sessions, as far as we've picked something off to be able to build a solution around it and make a big difference.
No, I'm looking forward to that.
So, well, perfect, Andy. I think this was a great episode. And again, highly recommend you go back and listen to, well, really all of our podcasts for sure. And by the way, make sure that you're recommending the podcast to folks. Tell them to download the post. Tell them to follow the podcast. That'd be great. And shout out too if you like the content. Shout out if you don't like the content. As far as that goes, give us some feedback.
And if there's a subject you want in the future, let us know that too.
Absolutely. Yeah, we've had a couple of requests already for that. So excited about future podcasts for people requesting specific things. So looking forward to that. We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledynehealth.com. That's pulse@teledigmhealth.com. For more information or general inquiries, please visit teledynehealth.com.